Good morning, guys. Welcome back to Legal Medicine channel. So today we'll be discussing on a topic called keratoconus, and this is a very important concept because they tend to ask this question in your university exams. Especially, they keep asking this question as a 4-marker in your university exam. So let's discuss about keratoconus in detail. Okay, the name itself tells me that something related with kerato and something related with conus, right? Kerato means cornea, conus means conical. No, like cone. The cornea becomes conical. If you look at this particular diagram, the cornea here is becoming a conical thing. So it's a defect, guys. So coming to this defect, it is basically a progressive non-inflammatory bilateral ectatic condition of cornea in its axial part. So each and every word here has a meaning. Okay, it is progressive, that is the onset is completely insidious. Okay, it is not sudden in onset. And coming to non-inflammatory, this tells me that it is not due to some inflammatory pathology, like it is not due to some infection, or it is not due to some external cause, like externally some object or some particular foreign body is not causing this. It is not inflammatory, and it is bilateral. Both the eyes are involved, and it is an ectatic condition of cornea in its axial part. And it usually starts at puberty and progresses slowly. Okay, it usually starts at puberty and progresses slowly. And the puberty here gives me a clue. Okay, usually during puberty or after attaining puberty, there will be hormonal changes. So probably the etiopathogenesis, if you look at the etiopathogenesis, it could be hormonal or endocrinal in nature. There is some hormonal pathology that you tend to see in this particular disease, and progresses slowly. So it's a developmental condition. Okay. If you look at the etiopathogenesis, the etiopathogenesis is not clear yet, but various theories are proposed so far, and we can label it under developmental condition, like because it progresses slowly and it's a degenerative condition. And again, see, like puberty is involved, so some genes are involved and other things are involved, right? So it's an hereditary dystrophy and endocrine anomaly, because hormones are involved, it is an endocrine anomaly. And also, if you look at this particular disease, okay, also if you look at this particular disease, it is becoming cone-like. That means the central and the peripheral cornea, which is there in this particular area, is thinning out. And because of its thinning, it is actually protruding forward, right? Because in order to protrude forward, the entire cornea has to thin out and then protrude forward. So that is what they're telling you, that it's thinning out because there is defective synthesis of mucopolysaccharide and collagen tissue. And that is the reason it is protruding out in form of a cone. That is the reason you call it as keratoconus. And coming to clinical features, symptoms are, whenever you have this kind of pathology, whenever you have some pathology with cornea, involvement of cornea, you tend to see two types of things like myopia or hypermetropia. Usually we tend to see myopia or hypermetropia. These are errors of refraction, right? So because this is conical in nature, you tend to see myopia. And because the disease is progressive in nature, because as the disease progresses, the myopia keeps increasing. So that is the reason it is called progressive myopia. And as and when it comes out, as and when the protrusion is too much, then you tend to see astigmatism as well. Cornea, because cornea is involved, you tend to see astigmatism, which is irregular in type. Okay, you tend to see irregular astigmatism. And because, see, if at all it is myopia in early cases, because if it is, because it's progressive in nature, in early cases you can treat myopia by giving correcting the lenses properly. By giving good correction, you can actually give proper vision to that person. But then once irregular astigmatism sets in, so even correction with glasses will not improve the sight. That is what you should remember. And coming to signs, window reflex is distorted. Placidodisc examination shows irregularity of the circles. And if you take keratometry, again, you tend to see extreme malalignment of Myers and increase, and the keratometric values. If you see the normal keratometric value, it is 45 diopters. But then in patients suffering with keratoconus, the keratometric values keep increasing. And based on the increment, you again classify it under mild, moderate, severe. Classify the disease under mild, moderate, and severe. When do you call a patient as mild? When the keratometric values does not exceed above 48 diopters. When do you call him a moderate person? When the keratometric values range between 48 to 54 diopters. And when do you call that particular case a severe case? When the keratometric values are more than 54 diopters. Okay, that is what they're telling you in this particular sentence. And if you take photokeratoscopy, reveals distortion of circles. Slit lamp examination, it's really important. I told you there is thinning and ectasia of central cornea, and because of that you tend to see opacity. And Fleischer ring, this is important, guys. Fleischer ring appears at the base of the cone, and fold in the cement membrane and Bowman membranes are seen. And walk lines, walk lines are seen, and these lines disappear with external pressure on the globe. This is a peculiar feature of this particular disease. And on retinoscopy, yawning reflex is seen, and then eye oblique irregular astigmatism is obtained. On distant direct ophthalmoscopy, D for D, so you tend to see oil droplet reflex. That means you tend to see an annular dark shadow, and this separates the central and peripheral cornea. And Munson sign is really important. Munson sign is nothing but whenever the disease progresses, whenever the disease progresses, whenever the patient looks down, the cone-like cornea pushes the lower eyelid forward, and that focal bulging of the lower eyelid when patient looks down, and this is only positive in late stages, because in order to do that, the cone-like projection should be very much high. The cone-like projection, the length of that projection should be very much high, and that is only seen in late stages. Okay, that is called Munson sign. And coming to corneal topography, shows me formi fruste, and this is nothing but this is the earliest subclinical form of keratoconus. Okay, so this is keratoconus. I told you placido disc examination shows me irregular discs, and this is placido examination. And if you look at this particular thing, this is nothing but these are these are rings, that is Fleischer rings. Okay, these are Fleischer rings, okay, seen in the patient suffering with this keratoconus. And this is Munson sign. I told you, right, when the increment or when the conical projection is in late stages is very much that there is increment in this particular length, then that pushes the lower eyelid forward, and then you tend to see that little bulge in the lower eyelid. This is called Munson sign. And this is walk lines, guys. This is a thing that you see in keratoconus. And coming to morphological classification, I told you cone. So basically it can be classified as into nipple cone, oval cone, and globus cone. When do you call nipple cone? When the size is below 5 mm, and oval cone when the size ranges from 5 to 6 mm, and globus cone when it is really enlarged, that is greater than 6 mm. And complications are you tend to see acute eye drops due to sudden rupture of the Siemens membrane, and this condition is characterized by sudden development of corneal edema, and this is associated with because edema is there, defective vision is seen, and then pain is seen, photophobia and lacrimation are seen. So development of acute eye drops and corneal edema, and because of corneal edema you tend to see defective vision, pain, photophobia and lacrimation. And treatment is simple, guys. In early stages, because the myopia is not too much, you can correct it with giving proper lenses. And once astigmatism sets in, then then you cannot correct it by giving lenses. Okay, that is because of astigmatism, like I've told you before. And coming to contact lenses, rigid gas permeable contact lenses can improve sight in early cases only, guys. Again, once astigmatism sets in, you cannot even prescribe contact lenses also. And coming to intacts, that intacts are nothing but they are intracorneal ring segments and are reported to be useful in early cases. And corneal collagen cross-linking with riboflavin and use of ultraviolet A rays may slow down the progression. And final treatment, once this particular disease progresses to an extent wherein you tend to see the later stages, complications of that particular disease are seen usually in later stages, right? So if the patient comes to the clinic in later stages, then you'll go for penetrating keratoplasty or deep anterior lamellar keratoplasty, and this is the final thing. Only this can resolve the issue permanently. Okay, this is all about keratoconus. And thank you guys for spending your time and listening to keratoconus. Thank you once again. Bye bye.